Welcome, 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 welcome to week 12. You know what, coders? We have 4 more weeks and we've made it to week 12. So there's no turning back. We can do this and we are so proud of you. This week, we'll be diving into cardiovascular and digestive systems. These are two powerhouse chapters that show up again and again and again on these exams. So remember, coders, you're not just learning to code, you're becoming forensic, accurate, certified, and ethical. That's the face of medical coding, and you're doing it the AMCI way. Now, let's get to it. We're going to welcome the team. Introducing your AMCI instructional team, Miss Dolly, Miss Bianca, Miss Mills, Mr. Sandeep, Miss Jayla. Yeah, Miss Jayla, you all don't hear her. She's behind the scenes. But these are the brilliant minds who write your scenarios after ChatGPT. They go through that pass process. They write and record your lectures and they support your success. So, welcome. And please say hello to them. They are in the chat. And let's not forget the AMCI interns. We have over 30 interns. They are talented and committed interns, and they do a lot. You'll see them in Discord, organizing and working in game nights, and building. They're building their portfolios. They are destined to be world class. A lot of them are trying to be dual certified, and trust me, that is, one of the highest levels that you can achieve in medical coding. All right, now let's go ahead and let's tackle week 12 with purpose and pride. We do have a disclaimer. If you're not familiar with CPT coding, we highly recommend that you review our beginners lectures. There are two lectures specifically CPT Coding for Beginners, Part 1 and Part 2, that break down CPT coding. And I recommend that you begin here, then take this course in order. What's going on at AMCI as it pertains to you in this YouTube course? Well, as I've said before, we have 4 more weeks. So what's next? It's time to exam prep. After 16 weeks, you will need to exam prep. And over the next 4 weeks, I'll be sharing tips on how to prepare for the medical coding exam in the most cost effective way possible. So you might say, hey, aren't we exam prepping now? No, we've integrated some test taking techniques, but our goal for this course is to provide instruction on medical coding, instruction on guidelines, right? Instruction on those guideline nuances. That's our goal. Because once you get over those hurdles, exam prep should be an easy ride. Now, I want to let you in on something I've never done before, ever. In all my years as an instructor, I've never reviewed other people's course content, never reviewed any other instructor's course content because I never wanted to subconsciously absorb someone else's material. Everything I create at AMCI, the charts, the concepts, the way I break things down comes from within. I don't know, it's just natural. It just, it just is. But this time, I'm doing it for you on your behalf. I'll be watching some of the YouTube instructors out there and giving you my honest thoughts and recommendations. And I may include them in my recommendation for your test preparation. What am I looking for? Well, I'm looking for cost efficiency. So they can't like give you a little bit on YouTube and then drive you to their website where you have to pay for a full course. Absolutely not. Accuracy. Yes, so they have to know what they're talking about, right? Yeah, you all would be upset with me if I said, hey, go watch this instructor and they really don't know. So, also simplicity. Are they easy to understand and follow? That's important. Those three things. That's it. Now, I hope you truly understand I'm doing this for you because your success is my mission. And I don't believe that I will adopt their concepts. I truly don't believe I will. And I also think that right now, if you see similarities in instruction, if you see our course looking similar or the way I teach similar to someone, it's either one or two things. Number one, it's a coincidence. Number two, it's not. So if it's not, just know that it probably came from here because that's what we do. We create, create, create. All right. So, test prep information will be provided over the next 4 weeks, and I'm going to need your help. So, I need you to tell me. How are you going to tell me? Well, when you fill out the survey, there is a section for you to tell me what's good about another YouTube course. They have to be on YouTube, right? This is a YouTube course, right? All right. Um, I think that's it. What else is going on at AMCI? Well, of course, the AMCI game night. We call it Friday Night Live. And trust me, it is fun, fun, fun. Go ahead, it's in Discord. Go check it out. Fridays at 7:30 p.m. Eastern. So that means it's 6:30 Central and 4:30 p.m. Pacific. Also, introduction to, well, IMTAP. It's interactive medical terminology and anatomy and physiology. That is also I'm in Discord on Wednesday nights. Speaking of Discord, how do you join? We keep hearing that. We keep hearing, "Hey, the link isn't working." Well, it's not working because it's on Discord's end. We keep specifying that we want this link to not expire, but for some reason it's expiring. But we do check the link on your syllabus. So if you want to join Discord, go to the syllabus. That's where the instructions are, and that's where the most up to date link will be. So, Discord, how to join. Number one, become a YouTube member. Click there. Yes, it does cost. It costs. Why isn't it free, Mrs. J? It isn't free because there are people out there taking our content and reproducing it, so they have to pay. Not a lot, but we're not going to give it to them. And therefore, everybody, kind of has to pay the price. No pun intended. And it's unfortunate. But number two, after you become a member, to join Discord, click here. That's where the most up to date link is, and we've checked it as of this recording. And also, after you click the link to join Discord, you're going to land in Discord, and then you're going to be able to see your name. And right here, I call it cogwheel, other people call it settings. Click on that settings button, boom, because what you want to do is link your YouTube with your Discord, right? So we're going to click there. Then we're going to click on connections. Then we're going to locate YouTube. Click on YouTube, then follow the prompts. You will be linked and you will be able to participate in Discord. And if you kind of jumped in on this class, just to let you know the books, not only for this class, but for weeks 9 through 16, go check out the syllabus on the website www.amcicoding.com/YouTube course. All right, so the books are HCPCS Level 2, CPT 2025. Yes, if you're testing this year, make sure you have CPT 2025. Also, the step-by-step medical coding book. If you want to save money, you can get the 2023, the MCG 2025 edition. If you want to save money, you can get the 2024. All right. Don't forget to tell everyone about us. We need you to keep this going. So, this is for everyone. The more people who participate, the more content we can generate. So, tell everyone. And for those of you that have been telling everyone, thank you. Now it's time for me to drop a gem. What is a gem? Well, these are powerful, bite sized truths created by me, and this is pertaining or pertinent to coding to simplify complex medical coding concepts. Think of them as a coding wisdom that you can carry in your back pocket from me to you. All right? Here we go. So many of you have told me, hey, I struggle with the difference between modifier 51 and 59. When do I use them? Okay, coders, here we go really quickly. Remember, it's always going to be modifier 51 until there's something different about it, right? If it's a different procedure, different body or organ system, different lesion, different provider, different session, coders. If you find the difference, then use 59. If you can't find a meaningful difference, then go ahead and use 51. All right? So it's modifier 51 until you find something distinctly different about that procedure. And again, always reference your guidelines. Right. CPT is copyright of 2025 AMA. All rights are reserved. Keyword concept FTR Chun, AMCI Fab 7, AMCI ICD-10 CM Philip Tap, and MCG are registered trademarks of AMCI. CPC, CRC, COC, CPMA, CPB, CPPM, CPCO, and more are owned by AAPC. CCA, CCS, CCS-P, RHIA, RHIT are owned by AHIMA, and AMCI does not own the rights to these credentials. Goals of the presentation for week 12. Number one, we're going to review CPT coding for cardiovascular system, for digestive system. We are going to do practice exercises to test your knowledge, and I'm going to be dropping a gem or two during this presentation. And finally, we're going to bring you one step closer to CPT coding mastery. Before we get into the discussion, I do want to preface discussion that we will be showing the MCG, clippings from the MCG. Now, if you have a 2025 MCG, I want to show you how it's going to look because the images that you see in this lecture are from 2024. Now, just so you know, the FTRs, facts to remember, these are guidelines, and these are guidelines inside the MCG. And essentially, it is a condensed form of the guidelines. You know, you've seen it, and you've seen that the guidelines could be hard to decipher, especially if you've never seen it before. So these FTRs were created to help you study these guidelines more efficiently, cutting out all that fluff. And let me demonstrate. All right, so this is from the perspective of the ebook. If you have the ebook, this is what it should look like. This is your table of contents. So if we're going to look at cardiovascular system, on the left, I've highlighted it. These are the FTRs. You click on the link, scroll down one page, and here you go. All right, so the procedure will be in the first column, the code series, right? The second column. And the third column, these are your facts to remember, right? So sometimes you'll see keywords. Whenever you see keywords, those keywords should be in your documentation. And often, when you see words in parentheses, those should be in your documentation too. But if you are coding for pacemakers or defibrillators, it should be within this code series, and this is what you need to look out for. What are you coding? You coding for a pacemaker, defibrillator? Are you coding for the batteries? Are you coding leads only or wires only? Are you coding the system? When someone says a system, it's battery and wires. Or is this a leadless pacemaker? Then you need to determine if it's a temporary or permanent pacemaker. And you need to pay attention to how they are implanted. Is it through the veins or is it through the chest? The number of leads will come into play. The skin pocket creations. Is it is there a skin pocket creation? Just know they are bundled, the creations and revisions. Now, skin pocket repositions are coded when it's part of a removal of an existing battery. Also, if it's biventricular pacing, that's 3 leads, they're coded separately. And there is a code, a temporary code for body surface activation. Also, if you're coding for pacemakers that where the wires were inserted through the veins, we encourage you to use the pacemaker chart to grab the correct code. And do not code right heart caths with leadless pacing devices. So these are some facts you should remember. You're not going to remember these, but you should document, right? At the bottom of the page. Not all of them, but key. All right. And then you go to your next session. So this is what an FTR are. These are the guidelines. We've looked at all of the guidelines through the pacemaker and defibrillator chapters, and we came up with this is what you need to pay attention to. All right.
So, the cardiovascular system in CPT code series 3301 through 39599. And this section pertains to procedures on the heart and pericardium. And if you didn't know, the heart, we always, we assume that everyone knows what a heart is, but it's a hollow muscle organ that pumps the blood through the circulatory system by rhythmic contraction and dilation. If you like that definition, I like it too. I got it right from Google. I did. And the pericardium, as you can see, it is a thin membrane encasing the heart. All right. And it consists of an outer fibrinous layer and an inner double layer of serous membrane. That's a type of liquid. This section, the cardiovascular system, also consists of arteries and veins. Your arteries carries blood away from the heart, and the veins, they carry the blood back to the heart. And I don't know who developed this on this slide. I know I developed the slide, but somebody wrote this language here, and I thought it was pretty good. Artery, think of the A in artery, takes the cleansed blood away from the heart, and veins, they reverse it. The V in vein reverses the oxygenated or the dirty blood back to the heart so it can get clean. All right. So let's go ahead and review how the blood flows through the heart. Now, when you take your exam, you might have an anatomy and physiology question, and they may ask you, so let's review. In your homework, you should have reviewed that the blood flows this way. From the inferior vena cava, hopefully you can see my pointer, or the superior vena cava, oxygenated blood comes to the heart, and it's first lands in the right atrium. That's your first one. After that, it goes through a valve, and that valve is called the tricuspid valve. After the valve, then it enters the right ventricle. Then after that, it goes through another valve. This valve is located right here. We call this valve the pulmonary valve. Why the pulmonary? Pulmonary is for lungs, and it goes up through the pulmonary valve, through the pulmonary artery, and it goes to the lungs to get cleansed. After it gets cleansed in the lungs, then it goes right back out through the vein into, this is the vein, pulmonary vein, into the left atrium right here. After the left atrium, we have a valve, and that valve is called the mitral valve. Then it goes where? Into the left ventricle. And then there's one more door we have to go through, and I'm saying it's a door. I'm going to tell you why, but it's a valve, and that valve is the aortic valve. And then it goes through the aortic valve into the aorta, into the body. And this is the flow of blood right here on the right. So if you think about it, an atrium, right atrium, is actually a chamber. We call it a heart chamber. And I like to refer to a chamber as a room. If you watch old movies and, they refer to rooms as chamber, go to the chamber. All right, so the right chamber, that is a room. Then in order to get to the next room, you got to go through a door. And a door is very similar to a valve. A valve works like a door. It opens up so that the blood can go through. So you have room, right atrium, room, ventricle, valve, tricuspid valve is your door. Then the right ventricle is another room. The pulmonary valve is a door. The pulmonary artery is the hallway, right? It's the hallway because it's carrying the blood to the lungs for oxygen, for deoxygenation. So the pulmonary artery and the veins act as a hallway facilitating the cleansing of the blood. Then it comes back through to the left atrium. That's a room. Then you go through a door, the mitral valve. The left ventricle is a room. The aortic valve is a door, and that's the last door before you go to the aorta, which is the grand staircase to your body. It is the largest artery in the body, the aorta. All right, so hopefully that speaks to someone. If it doesn't, it's okay. Just take something away from that. Again, it works like this. If this speaks to you, if you looking at numbers, your chambers are your odd numbers, 1, 3, and 5, and your valves, and 7. And your valves are even numbers. And this is the order that they come, that the blood goes. So first atrium, then you have your valve. But look, let's just do the atriums. Let's do this, not the atriums, the chambers. So your first chamber, then your third chamber, then fifth, another chamber, then seventh, another chamber, and then the valves are in between 2, 4, 6, 8. So if that speaks to you, and to remember them, I say RAV, LAV, right atrium, right valve, left atrium, left valve, or right atrium and valve, left atrium and valve. And if you want to know what your, why am I saying valve? Right atrium and ventricle, left atrium and ventricle. I apologize. Now, if you want, and that's how you learned your chambers. Now, if you want to learn the valves, think about TPMA, two people make amends. The T in two is tricuspid, P is for pulmonary, M is for mitral, A is for amends. So whatever it takes to remember, or you can just write it down in your book, right? Yeah, you can write it in your manual. Also, the cardiovascular system is tied directly to the HAMIC and lymphatic system. So often you'll see references, and I just want to point them out. Key parts of the lymphatic system: spleen, bone marrow, stem cells, lymph nodes, mediastinum, and diaphragm. And this system maintains the fluid levels in your bodies and in the tissues of your body. And these and this fluid comes, well, it happens or occurs when fluids leak out of the blood vessels. Yeah, so there you go. And it's important for optimal functioning. The lymphatic system has to operate optimally for our immune system to also operate optimally. So our blood vessels leak into your lymphatic system, and that affects your immune response system. Now, let's get started and let's talk about cardiovascular system from the perspective of the table of contents. All right, so you begin first with the surgery. That's what it's called. It's called surgery, but it is the cardiovascular system and a definition. Then they begin with the heart and the pericardium, those procedures. And here you'll see the pacemaker and implantable defibrillator. That is one of the procedures that you'll be expected to know how to code, and we will review it today. Also, you come down, you'll see heart, including valves and great vessels. So that's going to be an expectation on the exam. And these procedures are on valves and only valves. You'll see the aortic, mitral, tricuspid, and pulmonary represented here. Also, here's endoscopic procedures on the heart, as well as venous grafting for coronary artery bypass, combined arterial venous grafting for coronary artery bypass, and arterial grafting for coronary artery bypass, and we call that CABG, and we will discuss this also today. Then you have your coronary endarterectomy. And under the arteries and veins section, you see your bypass grafts. And on the right, this is an image of an endarterectomy. This is removal pretty much of the plaque within an artery. And finally, there are endovascular repairs of the aorta, abdominal aorta, and iliac arteries. Also, there are procedures for hemodialysis in that circuit. And then here is the table of contents for the HAMIC and lymphatic systems. And this is your cardiovascular system, pretty much. The heart, arteries, and veins. And these images are in your CPT manual, so don't feel like you have to remember everything. Only remember what you have to. And sometimes you have to remember some guidelines, but remember this: surgery guidelines, those general surgery guidelines, are applicable in this section. We're going to review specific guidelines, but these general surgery guidelines are applicable. They do not supersede a specific guideline, but if there's none, if there's no conflicting guideline and this is applicable, you definitely have to apply it. All right, so we reviewed these guidelines the last 2 weeks, and they are standard across the board. What CPT codes is or are reported? A, 33213, 33233 with a 51 modifier. B, 33213, 33233 with a 51 modifier. 33235 with a 51 modifier. C, 33214, and D, 33212, and 33233 with a 51 modifier. Physician places a single chamber permanent pacemaker with a dual chamber, replaces a single chamber permanent pacemaker with a dual chamber permanent pacemaker. All righty, you have 2.5 minutes. Let's start now. Well, I see a lot of you have gotten this answer quickly. Wow, that's impressive. Impressive. Okay, got a question. Can you use that chart for this scenario? What do you think? Even though it doesn't say. Absolutely, you can. When the documentation does not actually specify, you can indeed, because it will specify if it's epicardial placement. The default is Venice, right? Yeah, because that's the least invasive. It's not as complex. Just thought I would tell you that. So let's go ahead and let's solve. Okay, Ace. So we know this physician replaced a single chamber permanent pacemaker with a dual chamber pacemaker system. So here are my inventory. Replaced, I put an ED, it's okay, you can do that too. A single chamber permanent pacemaker with a dual chamber. That's it. And I'm going to go over and look at the guidelines from the perspective of the MCG manual. So essentially, it says, I just want to review them. You need to know what you're coding for. Pacemaker, defibrillator. Are you coding for batteries, leads, a system, leadless? What are you coding for? And the type. Are you coding for temporary or permanent? Permanent. How were the leads implanted? Are they implanted transvenous or thoracotomy, thoracoscopically? And what are the number of leads and electrodes? Was a skin pocket mentioned? And there wasn't. And below, we continue. Biventricular, no mention of that. Pacing lead is coded separately, and so forth. We'll look at these a little later, but these are not applicable, so let's continue. So we know we are replacing, and let's start with 33212. This is coming up incorrect because it's the insertion of a pacemaker pulse generator only with existing single lead. We don't know that, do we? No, no. So we don't know if these are existing leads, but also too, we're inserting a single lead. And that's not what's happening because we're taking out the single lead and we're replacing it with a dual lead, right? So we're definitely going to get rid of this single lead because we're not putting in a single lead. We're taking it out. Now, the 33213, this is the insertion with existing leads, with existing dual leads. This could be, but we don't really know. But let's look down in this parenthetical note right here, or guideline. It says, do not report 33212, 33213, and 33221 in conjunction with 33233 for removal and replacement of the pacemaker pulse generator. So we can't use it, right? So it says don't code them together when you are removing and replacing a pulse generator. So where are we? I see it being used there and there. So let's take a look. This is 33223. This is the code for relocation of skin pocket for implantable defibrillator. We're not even coding a defibrillator. There's no reason for us to be coding for it now. And it says C is correct. And a lot of you said C because this is the code for an upgrade of implanted pacemaker system, conversion of a single chamber system to a dual chamber system. And this includes any removal of previously placed pulse generator and testing of existing leads, insertion of a new lead, insertion of new pulse generator. So this indeed is our code. And don't forget, and this is called conversion when you're converting from single to dual. It says do not report 33214 in conjunction with these codes. So always read those parenthetical guidelines. And if you got that correct, outstanding. But I do want to leave you with this. Always read your parenthetical guidelines. They will help you. They will. Now, I asked you if we could use the chart, right? And we can use the chart. So essentially, we have to look for the upgrade. Upgrade, single chamber to dual chamber, 33214. And it says it includes the removal of existing battery. So your answer is C. Way to go. Let's go back here. I got a little ahead of myself. Right, so my on clicks are a little off, so bear with me. All right, so how would you code this procedure? 33214, A, B, 33203, 33213 with a 51 modifier, C 33202, 33213 with a 51 modifier, and D 33208, and 33213 with a 51 modifier. Mr. Jackson has a history of bradycardia, presents for epicardial lead placement via median sternotomy to the right atrium and right ventricle. A dual pacemaker generator is then inserted subcutaneously. How would we code this procedure? Okay, coders, you do have 2.5 minutes, and your time begins now. All right, you all are rocking it, and don't be hard on yourself. It just means slow down just a bit because you got it. Now I'm going to highlight these key words: bradycardia, epicardial lead placement via media sternotomy, right atrium, right ventricle, dual pacemaker generator. Here are my keywords. So if I'm looking at these keywords and I'm processing, I'm like, okay, you can write your own notes. Definitely write what's next to it. Bradycardia means this patient had, the pace was too slow. Epicardial lead placement means that they went through the chest, not the veins. When you see median sternotomy, if you see any otomies, likely they went through the chest. Right ventricle, right atrium means that there are two chambers here. So this is a dual chamber pacemaker system and generator. Now I am going to get rid of these two because both right atrium and ventricle mean that there are two chambers, and that means dual chamber. And then there's a subcutaneous battery. All right, so these are my keywords. And I just want to tell you again, when you see the otomy language, that means an incision was made through the sternum, the sternotomy through the chest. So that means we can't use that chart. We got to just code it on our own, and we can. Also, this was a dual pacemaker system, so one lead was in the atrium and one lead in the ventricle, 2 leads. And of course, a battery. And we have our guidelines, and pretty much just knowing the meanings and knowing those definitions will help drive your answer. But these just really make you think, what are you coding for? You're coding for a pacemaker or defibrillator? What type? How are they implanted, etc. So we kind of have the gist. So let's go ahead and code it. And a lot of you have done phenomenal. All right, so the first code that we encounter is 33214. This is the code that we've just looked at. This is a conversion from a single to a dual chamber system. This is not happening. We are implanting a dual chamber system. Yeah, we're not upgrading anything. So A is a distraction, and it's got to go. Now let's look at the other codes. All right, so the next code it's telling us to look at is D. It said D is wrong, 33208. Well, why is it wrong? Okay, well, the parent is saying that this is an insertion of a new or replacement of permanent pacemaker with transvenous electrodes. We did not go through the veins. So if the common language portion is wrong, then the indented and or child is also wrong. So 33208, you gotta go. You're a distraction. And that leaves us with 33202 and 33203. And I like it. Look at the parent language. Insertion of epicardial electrodes. And I love it. I love it. And I love the fact it has our exact language. It says, example, median sternotomy. This is an open incision. I love it. Now, the difference between 33202 and 33203, 33203 is endoscopic approach. One was incision, the other was using a scope. Our documentation says that, hey, a median sternotomy took place. So our answer, well, we're going to get rid of B, 33203, and our answer will be C. And it tells you in the parenthetical guidelines, when epicardial lead placement is performed with insertion of the generator, report 33202 in conjunction with 33213. I tell you, these parenthetical guidelines will help you when you are coding these pacemakers and defibrillators. So let's do our due diligence and look at 33213. This is the insertion of pacemaker pulse generator only with existing dual leads. And if you said C, outstanding. You all are rocking. I do see people had various answers. Majority of you said C, but enough of you said D. I hope that you saw why it was wrong. And I know that you're going to rock it next time. I know it. So pay attention if it's veins through the veins or through the chest. All right. I think you all are ready to move on. I do. And we're going to talk about CABG, coronary artery bypass grafting. Yes, well, what is it? Well, it's when your coronary arteries, so the arteries around the heart, get blocked. And sometimes you're going to have to create bypasses so that blood can flow through the heart. On the left, you see the yellow around the arteries and veins. Well, this represents blockage, right? And if you look in the middle, this is what it looks like. It restricts blood flow. So we have a little problem, and the way we're going to take care of it is we're going to have these bypass. We're going to bypass all that blockage and go from the aorta directly to the artery. So we've opened up the blood flow. And these bypass grafts are coded according to the number and type of grafts there are. So on the right, can anybody tell me what type of bypass graft is it? Is it a, what do they call it? Okay, is it a single, a double, a triple, or a quadruple bypass graft? Go ahead, type your answer in the chat. Let me see if you did your homework. Let's see. Outstanding. Everybody's saying double. You can see those two graphs, right? Two, double, outstanding. All right, so let's go ahead and look at some of these graphs. Where do they get these graphs from? Well, they get them from the patient. Often they'll get them from the lower extremity, right? So as you can see, you have lower extremity veins and artery. And let me tell you, they like those veins. They really like this great saphenous vein. They like it. See how long it is? It extends all the way down the leg, so they can abstract that vein and cut it up and make a ton of grafts. They can probably make two or three grafts. So it is very popular. And when you abstract the vein or the artery from the lower extremity, you don't code that separately. So if a harvest of a vein takes place from the lower extremity, you don't code for it, it's bundled. Now, on the other hand, if the vein is abstracted from the upper extremity, it is coded. We do code the harvesting. So if you harvest a vein, you're going to code 35500. If you're going to harvest an artery, 35600. And again, remember, those lower extremities are bundled into the treatment. Let that marinate. But one of the most popular to abstract are your internal mammary grafts. Yes, often when they're carrying out a open procedure and they're opening your chest, look at the internal mammaries. They're sitting right here. And they can use those for grafting purposes too. So if the internal mammary is used, that too is bundled. Again, we're only talking about upper extremities, so we're really talking about arms and lower extremities, legs. If you have on your test anything other than an upper extremity, your arms, then it's bundled. All right. So you don't have to remember about this internal mammary. Just know those arms are bundled. So this is how you code grafts. The lower extremities, the lower legs are not coded, they're bundled. Upper extremities are coded, and sometimes they could take or abstract or harvest the femoral popliteal vein, and that is coded as well. It has its own code. So you're going to need to remember that. Pay attention to that fem pop. The fem pop has its own code. Also, they may have to endoscopically harvest the lower, the upper, and the fempop. Anytime they have to pull out that endoscopic equipment, we will code for the endoscopic procedure. While we're not coding for the harvest per se, we are coding for the use of endoscopic equipment. Now, I want to draw your attention to the code series. All right, so you have 8 arterial grafting for coronary artery bypass. Anytime you use arteries, you're going to get your codes from here, and there are 4 codes. Anytime you use veins, you'll get them from the codes from venous grafting only for coronary artery bypass. Look at that word only, venous grafting only. If you're only using veins, you use this code series. Why don't we say this over here with the arteries? Because you can use this code series when you're coding both artery and veins, but you cannot code from the veins only section if you're coding both arteries and veins in the same setting. You'll have to grab your code, your vein code, from the combined arterial venous grafting for coronary bypass. So yes, you got to get your veins here if you have both. Now you'll get your arteries from the artery section and your veins from the combined section when you're coding for a combination of both arteries and veins. And we call those combos. I said a lot. Now I want to know, are you with me? Yeah, I'm being quiet. This is your time to let me know. Yeah, it is a lot. And remember, the playback is our friend. All right. Okay, now I just want to review the facts to remember when you're coding these bypass graphs. Also to remember, you don't use this veins only for combos. And if you want to put this in your manual, go right ahead. Do not use for combo. Now, let's look at these FTRs, facts to remember. When you're coding CABG, you need to know what type of graft is this? Is this arteries or veins? Number 2, where is the graft or where was the graft being harvested from? Is it upper extremity or lower? Remember, upper extremities require a harvest code. Lower extremities, those harvests are bundled. You do not code for lower extremities. How many grafts are you coding for? Is it 1, 2, 3, or 4? Is this a combo? Arteries and veins. Remember, choose your arteries from the artery section, and you're going to code those first, and then your veins will come from the combination codes section. If you have a femoral popliteal graft or a FemPop, use code 35572. If you had to procure these grafts using endoscopy, you're going to have to use the appropriate code 33508 or 33509. Whether it's a lower or upper, you have to use that code. If an assistant surgeon just harvests the graft, then they will use a modifier 80. If you are coding for percutaneous ventricular assist device or PVAD, use 33990 through 995 and 33997. And this is what a PVAD looks like. And a PVAD helps support the heart until the heart can be repaired. And don't forget your common primary keywords: arteries, veins, combination, combo, combined heart, mammary, brachial, radial, saphenous, femoral popliteal, or FemPop. And if you want your FTRs and you want to put them below, they can look like that as well. When I say below your codes, the applicable codes. So right in the section where the codes are, so you can glance. All right, are you ready for a coding exercise? Okay. Someone say, yep. All right. You know what? This is Jay. Come on. Let's do this later. All right. Let's go back. Come on. All right, no problem. All right. Select the CPT codes for this procedure. A, 33536, B, 33513, C, 33513, 35600, and D, 35600. Physician performs a 4-vessel autogenous coronary bypass on a patient who had a previous CABG 2 years ago for coronary artery disease. Utilizing the saphenous vein harvested by the surgeon performing the graft surgery, select the CPT code for this procedure. Your time begins now. All right, I gave you a little more time. I did. Okay, so people were starting to get it. Okay, all right. So here are the key words. We had a 4-vessel autogenous coronary bypass. All right, so think about 4-vessel. And the patient had coronary artery disease. The saphenous vein was harvested. I think we have enough to code. 4-vessel autogenous bypass, coronary artery disease, saphenous vein. All right, you're either going to code arteries or veins. All right, coders, which one are we coding for? Is it this one, this one, this one, or this one? What are we doing? Which one do you think it is? Is it a single, double, triple, or a quadruple? That's right, it's a quadruple bypass. So they need a long, long graft. Trust me, it doesn't say, it says we only use the saphenous vein, and you know I showed you that is the longest graft that we often use and code for. So if you need to reference your guidelines from the MCG, they are here, but I think we have enough to move on. All right, so my inventory is below, my codes are here, and it's saying that 33536 is incorrect. Go ahead, type in the chat. Why is that correct? Incorrect, excuse me. Why is it incorrect? That's right. Someone said this is for arteries. Yes, they used arterial grafts. What is the saphenous? It's a vein, right? So it's a vein. So we're not going to code for any arteries, and A is incorrect. Now let's look at the others. And and D is incorrect too, because they're both coding for these arteries. Gotta go. Now we have B and C left, and it's saying that this 33513 is correct, and it's correct because this is coronary artery bypass vein only. Yeah. And we obviously they cut up those veins, that saphenous vein, and made 4 grafts. So this 33513 is correct, but the difference between B and C is the harvest, 35600. So if you look at first of all, you don't harvest the lower extremity, the saphenous, right? It's bundled. But if you didn't know that, if you just read it, it says harvest of upper extremity. Remember, the saphenous goes down the leg, that's your lower extremity. And so therefore, 35600 cannot be coded. And then your guideline says that lower extremity is bundled. It's bundled into the treatment. So the answer is B. Aha! Someone said I had an aha moment, and you know what? That is priceless. You ready for the next one? You all are rocking. Come on, we got more. Let's get it. That's right. Someone said, let's get it. Let's go. Yes, pay attention. Is it a vein? Is it an artery? Or is it combo? All right. So we've got what CPT codes are reported? A, 33534, 33512, 35572. B, 33534, 33515, 35572, 356, 33508. C, 33514. 35572 35600, D 33533 33521 35572 35600 33508. Patient with atherosclerotic heart disease, ASHD, had 3 three veins, 2 artery, CABG, using the saphenous vein, the fempop vein, and the radial artery, harvested by the surgeon performing the grafts. The venous grafts were procured using endoscopic harvesting techniques. Okay, coders, take your time, and if you need, classify your grafts. Classify, write them down, and section them off so you can kind of see what you're coding for. Your time begins now. We slowed down just a little bit, and it's okay. All right, let's work this together. Outstanding job, everyone, for attempting it. Keywords: ASHD, atherosclerotic heart disease; 3 venous; 2 arterial; CABG. They use the saphenous, fempop veins, and the radial artery. And those veins were harvested using endoscopic harvesting techniques. Remember, I said we don't code for the harvest, but we do have to code for that harvesting technique, regardless if it's upper or lower. All right, there's no harvest code for the veins per se, but the harvesting technique of the veins a little different. All right, now these are my key words. That diagnosis, ASHD, 3 veins, and I sorted them out. I said, okay, they use the saphenous vein and the fempop for these 3 veins. So one of those was fempop, the other 2 saphenous. And the fempop has a harvest code. We have 2 arteries from the radius, and that's the upper extremity, radial, radius, upper arm. And this is indeed a combination. These are my notes. Although it's not in here, I'm saying it's a combo. And the veins were harvested endoscopically. Now, I'm going to look at my FTRs to kind of to remind myself. And if you look below down here, here's a coding tip. Your upper extremities are your radial artery, your brachial arteries, artery and veins, your ulna, your cephalic, your bacillic, brachial cephalic. Wow, that's up there. Subclavian. All right. So these are your upper extremity. Disregard that internal mammary. I'm going to fix this, but let's really stay with the basics. Radial, radius, your brachial, the brachial, the ulna. All right. So let's just cephalic arm. If it says arm, that's it. Bacillic. Now this internal mammary, I don't know how that got there. We're going to remove that. You remove it. Get rid of it. All right. Now we know we have 3 venous, 2 artery, and that's 5. And we got a code from the combination section. So I think we can eliminate something right now. That's why these codes are up here. And it's saying 33514 got to go. The reason this has to go is because when you are coding from the coding a combination, arteries and veins, you may not use veins only. So any code from the veins only section gets tossed. So that's indeed what this is. So this is the vein only section. Both 33514 and 33512 are incorrect. And so that's going to eliminate A and C. Go back. A and C. Let me just line it up just a little bit for you so you can see. I guess that's the best we can do. It doesn't line up well. All right. So are you with me? So just knowing that we eliminated 2 answers. Now, I like to go ahead and make myself a little chart so I know what I'm doing. All right, so we have vein number 1, that's saphenous. Vein number 2, that too is saphenous. Vein number 3, we use the fempop. And arterial 1 is radial, arterial 2 is radial. That's important because some of these get a grafting code, right? So let's just work on the grafts and then we'll work on the harvests. All right, so 33533 is coming up incorrect because this is coding for a single graft. And if we looked here, we have 2 arteries, not 1, 2. So we're going to code for 2 coronary arterial grafts. All right. So we, on the strength of that, we've just eliminated. What did we eliminate? We eliminated D on the strength of that. But let's keep going, everyone. So we have our arteries, and you always sequence your arteries before your veins, right? Next, you get your veins from the combination section. So let's go on over, and these are add-on codes too. So let's go over 33519. This is for our 3 veins. We have 3 veins, vein 1, 2, and 3. So we are coding 33534, 33519. Now we have 3 more codes. Let's see what we have coded, what we're coding for. 33572 is the code for the harvest of the pop. Remember, we have to code for that harvest. Also, 35600 is the harvest of the upper extremity, right? There you go. And it says 1 segment for coronary artery bypass. We only had one segment. There you go. Even though we made 2 grafts out of it, but there you go. And 33508, this is the code for the endoscopy, surgical, including video-assisted harvest of veins for CABG procedure. So anytime you do an endoscopic harvest, you have to code the endoscopic technique. And the answer, B, 33534, 33519, 35572, 35600, and 33508. And our answer is B. That was kind of long, but did you find, yay, someone said yay, and yay, someone's had eliminated some things, outstanding, but did you find that if you just kind of categorize what you're doing, that it'll make sense? Yeah, it helps. It does help. But the more you do it, the better you'll become at it. Yeah, writing out helps. All right, so we're almost at the end, and we have to talk about vascular families, Appendix L. So outstanding job with coding CABG and pacemakers and defibrillators. Now let's talk about these vascular families. And you can find the vascular families in Appendix L. Now, what is a vascular family? Well, a vascular family is defined as a family of vessels, particularly arteries and veins. And these arteries and veins, as you can see on the left, you can't really, I don't think we can appreciate how much these arteries and veins branch. They branch off of one another. And these vessels or these branches have families, right? And just like a family, a real family, a family tree, one branches off of the other. So one part of the family keeps branches off of the other, just like an actual family tree. And on the right, this is the old Appendix L, but I loved it because you could see how they branch. You start here, there's your first order, then you branch off in your second order, then you branch off, you got your third order generation, and then you go from that. This is beyond third order branches. But what if I took that and just turned it once? And it looks like this. Act like this is your grandparent or your great-grandparents. Here are your grandparents. There are your parents. And there you are and your siblings and your cousins and so on. So it is a tree. It's like a family tree. And these families of arteries and veins, they branch off, and sometimes diagnostic procedures may be necessary within these branches. So what a doctor does is they'll take a catheter and fish the catheter to the location that they are trying to reach. Now, let's say that a patient has some narrowing of an artery. The doctor will take that catheter to that location, and sometimes they carry out procedures right there. They might open it up. They may do a plethora of things. However, the important thing is that they have to determine where it is, and you have to use Appendix L when you're coding to properly, oh, I hope I didn't touch my screen, to properly code for that procedure. Procedures like, let's say someone has atherosclerosis, that's narrowing of the arteries, or even a cardioembolic stroke. Those are blood clots from the heart that migrate. And here's one right here. These right here, these are vascular family, and we call these cervical cerebral, right? Because they are above the subclavian or the sternum. They're above the clavicle and they're up into the brain. And you can have a plethora of circumstances and conditions that require the doctor to diagnose that condition. You know, when people have strokes, whether it's hemorrhagic or trans ischemic attacks, they diagnose them by knowing the vascular family, and we code it because we also know the vascular family. Specifically, we have to know what order. That's what we code. Is it first order, second order, or third? Now, we'll talk about that in a minute. Now, there are two main types of catheter procedures. You have a non-selective procedure or a selective procedure. A non-selective procedure just means that catheter is going into the aorta and it remains there. There's no need to move it further. However, when that catheter moves beyond the aorta, it's considered to be selective. And then that's where we get to we get to code according to the order. Is it first? Where did that catheter end? And if it end at the first order, second order, third, beyond, that's what we code. Also, these catheter procedures are classified according to where on the aorta it is. Is it above the diaphragm or below the diaphragm? Is it above or below? If you're coding for those procedures, the cervicocerebral procedures, you know it's above the diaphragm because they are in your head, neck and head. If it's below, then you'll code from that code series. So above the diaphragm and below the diaphragm. And just know, I think if you've done the homework, you know that the aorta spans the entire trunk, right? So your heart sits around here. The aorta hugs the heart and goes down your trunk to your iliac crest right here. So it's a very long vessel. So you will be expected to know what is selective and what is non-selective. Also, I talked about these branches and I talked about the first order, the second order, and third order. So here is an example. All right, so we know this is the aorta, remember? The aortic arch, which goes around the heart. And then the first stop is your brachiocephalic artery. That's considered first order. Next, common carotid, second order. And you can keep going up. You've got your third order, the internal carotid artery. And your fourth is your lingual artery. So each branch have codes. Each classification or each order has its own code, and we get these classifications from Appendix L. So if you haven't looked in your Appendix L, this is going to be a glimpse. Now, what if a surgeon carried out a catheter procedure? On this procedure, he's putting the catheter into the vertebral artery, and you're expected to code for it. There's no way we'll know that, right? So we're going to go to Appendix L and we're going to look for the vertebral artery. Yes. And this is what your arterial vascular family looks like. And because we know that the vertebral artery, one second, let me just make sure that I'm demonstrating it. Because we know the vertebral artery is above the diaphragm, how do you know that, Mrs. J? Because I see it on this chart. It is above the diaphragm, so I'm going to search for it on the part of the chart that's above the diaphragm. So if we're to look for the right vertebral artery, I kind of found it right here. But just to be efficient, I'm going to go ahead and highlight the path to the right vertebral artery. This is what the doctor is going to do. Most likely, he's going to go through the thoracic aorta, the upper aorta, right here on the left. Then he's going to fish that catheter to the innominate, the brachiocephalic. He's going to come right here. Okay. Then he's going to take that catheter and go to the right subclavian. So he comes in here, he's going here, then he's going here. And then it's going to go right to the right vertebral, right there. All right, so thoracic aorta, the brachiocephalic, the right subclavian, then to the right vertebral. That's how he's going to do it. And where you end up is what you code. So if you look at the top of each column, the first will always be your aorta. And your aorta will always be 36200. Then the first order for the upper diaphragm will be 36215. The second order will be 36216. Third order will be 36217. And third and beyond will be 36217. So that's how it's done. And you only code the highest order. And the highest order is the third order. That's where we end. And that's how you code it. Now, what if you had to code for below the diaphragm? Well, very similar to above, but the codes are a little different. And we'll review those codes in a moment. I think there's a little off, okay? I think this goes here. But your first order is 36245. I think it got missed when we moved it. Let me try and move it over. Come on. And you should go ahead and do this to your Appendix L. So if you're looking in there for something, your codes are right where they need to be. 36245 for lower, below the diaphragm. First order, second order for below the diaphragm is 36246. Third order below the diaphragm, 36247. And beyond, 36247. There is an add-on code, but it is not for beyond the third order. It's for additional orders. And it continues. This is still your lower diaphragm, so definitely make sure that you chun it. Now we are at the end, but I have 2 scenarios to code. If you'd like to be excused, you may, or you can stay and I'll code these along with me. All right, so you may definitely watch the playback. All right, so you've got 2 main types of catheter procedures, selective or non-selective. These are really your FTRs, all right? But these are your FTRs. Is it selective or non-selective? And it's selective if that catheter went beyond the aorta. If it didn't, it's non-selective and use a non-selective code. Is it upper or lower diaphragm? Which order is it? Is it first, second, or third order or beyond? And make sure you code the highest order. And anytime you have interventional angiography or angiogram, fluoroscopy, radiologic supervision and interpretation, closure of the aortotomy by pressure, all of these are coded separately. And don't forget to use Appendix L to verify your vascular family. Okay, coders, if you're able to stay, are you ready? All right. What is the CPT code for the procedure? It is not multiple choice, so you'll need to use your Appendix L. A patient suspected to have CAD arrives to the cardiac cath for diagnosis. A catheter is advanced from the aorta to the left subclavian, then manipulated deep into the left deep cervical branch. All right, coders, what is the CPT code? Let's walk this together. I think we should walk this so you can see where you get the CPT codes from. All right, so the patient has CAD. The catheter comes from the aorta to the left subclavian, then manipulated deep into the left deep cervical branch. And this is my inventory. CAD, catheter advance, aorta to left subclavian to left deep cervical branch. And if you want to change these so you can kind of see them a little better, so you can just say aorta, then to the left subclavian, and then left deep cervical. All right. So I kind of changed it up a little bit so you can see it like that. So you see the path. And essentially, I'm going to demonstrate it here. So you have left subclavian. First of all, here's your goal to get here. And so you go into the aorta, always start at the aorta. Then you go to the left subclavian. All right, this is the left subclavian. Then from the left subclavian, you get to the deep cervical. Going up, you're at the deep cervical. And that's it. Aorta, left subclavian to deep cervical. And look at the codes, it's right there. So let's go ahead and look at our Appendix L so that we can see from that perspective. And remember, left subclavian is up here. They went through the aorta, but the thoracic part of the aorta, then the left subclavian, and see how I wrote my codes above the orders? Then, although they didn't say it, they must have missed something. So the left costocervical, then to the left deep cervical. So they didn't mention this, but we can deduce that they got here this way, then the left deep cervical. But we code where they end. All right, coders, let me look in this chat and see. That's right. Some of you are nailing it. Outstanding. Outstanding. Look at that. Some people are just writing in the chat. All right, so it is here. You end at 36217. So that's our code, 36217. All right. Now that we've done it from Appendix L, let's go ahead and let's do another. And this is our last one.
Which codes best describe the encounter? A. 36245 7573626 modifier 75774. B. 36247 75716. C. 36217 75658. And D. 36247 75710. A catheter is placed in the aorta in retrograde fashion, which is directed into the right iliac system, advancing it to the external iliac. Dye was injected, and a select right lower extremity angiogram was performed, which revealed occlusion of the common femoral and profunda femoris. Okay, coders, your time has already begun. Okay, coders, how did you do with those keywords? All right, let's take a look at what I've done. All right, so for the key, if you want to go ahead and follow my key, it's on the top right. A catheter is placed in the aorta, right? And it was directed into the right iliac system, advancing it to the external iliac. Then dye was injected, and then a right lower extremity angiogram revealed occlusion of the common femoral and profunda femoris. So, the inventory catheter placed in aorta. That's important. Then, number two, then it was advanced or directed to the right iliac system. So we know it moved from the aorta. And when it moves from the aorta, is it selective or non-selective? Okay. Then, once it gets to the right iliac system, it's advanced to the external iliac, and then dyes injected, and an angiogram was carried out of the lower extremity, which found occlusion of the common femoral and profunda femoris, the arteries. Now, let's go ahead and let's have a little discussion about, let's just talk about where this catheter is. On the right is our anatomy. If we use our inventory list, we can just kind of follow along and almost see what took place. The catheter was placed into the aorta. Let's say they placed it here. Then they fished it down to the right iliac system, right here, right? We know this is the right iliac system because you can see the ilium right here, the actual anatomy right here, or the iliac crest, right? Then they went down to the external iliac artery. Then they injected dye right about here. And the dye enabled them to carry out an angiogram or angiography. And the angiography was of the lower right extremity. So they got to see all of these arteries. And after that angiogram was carried out, occlusion of the common femoral and profunda femoris. So right around here, the femoral artery, this is where they found some occlusion. And also here's the profunda femoris, the small branches. So they found some occlusion. And if you want to simplify things, if this is just like too much for you, this is the actual path. They went to the aorta, then to the right iliac, then down to the external iliac system. They injected dye and had that angiogram, and that's what happened. I'm going to let that marinate. Now, Now, let's look at the guideline, right? This is a clipping from the 2024 MCG. It is very similar to the 2025. Also, I clipped the guidance for code series 36245 through 36248 because the majority of the codes are within that code series, and also it's similar to the 36217. It's very similar. All right, so essentially we just have to answer these questions. Is it selective or non-selective? Coders, what say you? If you said selective, outstanding. Remember, anytime the catheter goes beyond the aorta, then it is selective. If the catheter is just inserted into the aorta and does not go beyond that aorta, then it is non-selective. So we're going to go ahead and answer it. It's selective. All right, coders, is this upper or lower diaphragm? Is it above the diaphragm or below the diaphragm? What say you? If you said below, very good. How did you know? Because all of the work was in the lower part of the body. Um, the the catheter was placed in the right iliac system. We know the iliac crest is below the diaphragm. Also, there was an angiogram of the lower extremity, and their condition was found in the common femoral arteries and the profunda femoris. So that's all lower extremity, right? So if it's lower extremity, it is lower or below the diaphragm. Now, next question. And I'm over here if you didn't know. I apologize. So, is it first, second, third order branch? Which vascular order is it? And I don't know. The only way I'll know is if I go look in Appendix L. Haven't done that yet. All right. Also, these instructions tell you to code the highest order. And it also says interventional angiography, fluoroscopy, radiological supervision and interpretation, closure by the arteriotomy, by pressure are coded separate. So we know that. And I'm going to tell you, even though we had an angiography, which is also an angiogram carried out, this angiography is not interventional. When they say, or they're speaking of the interventional angiography, they're talking about procedures that are um, hmm, interventional procedures that are more therapeutic, procedures such as stent within the artery or a balloon angioplasty. So something more than diagnostic. It appears that we have a diagnostic angiogram, and that's what happened. They diagnosed that occlusion, right? That so essentially, this is not our case, but we did have an angiogram, and what do we do? Also, it tells you to use Appendix L to identify your vascular family, and we are going to do that. So this is what we know. We know that we have a selective catheter procedure below the diaphragm, and an angiogram was carried out. Now, I want to take you to look at, I want you, let's go ahead and look at the code and let's study the language really quickly. All right, so here is the 36245 family. Let's read it. It says selective, that's our key word, catheter placement, arterial system, each first order abdominal, pelvic, or lower extremity artery branch. Sounds like our family, right? Within a vascular family. So this is this first order. We don't know if it's first, second, or third, right? But if you look down, you'll see your second order and your third order. But what you don't see any mention of diagnostic angiography or angiogram included. And in the FTRs, you don't see it mentioned either. And the reason it's not mentioned is because it will be mentioned in the code language. If it's bundled, it will say it. The code will say it. Now, typically we would just put it in the FTRs, but you have a number of codes that bundle the angiogram and you have some that don't. So we don't want to confuse you. So it's important that you read the code completely. So if we look at a code 36251, this is not our code, but this is our example. This too is a selective catheter placement, first order. But this is main renal artery. They're very specific about the artery, right? And this is for renal angiography, including arterial puncture and catheter placements, fluoroscopy, contrast injections, image post processing, Permanent recording of images and radiological supervision and interpretation, including pressure gradient measurements when performed, and flush a orthogram when performed unilateral. So it says it includes an aortogram, not an angiogram, or it could be, but it has to specifically say a flush angiogram. Angiogram and aortogram could be the same, but they're very, very specific. Okay, coders. So the code language will tell you, and this code language tells us that this angiography is bundled, right? But these codes, the angiography is not. All right. I digress, but I'm coming back. Now, let's go ahead and look at some of these codes and let's see if we can eliminate some things. And right away, I'm going to the 36215 family, and I'm noting that 36215 is first order, 16 is second, and 17 is third order. I like the language that says that this is selective catheter placement arterial system. I like that because it matches our key terms. It's selective and we know it's arteries, right? But what I am concerned with is when you get to the code 36217, and it's also present in the entire family, this is for the thoracic or brachiocephalic branch arterial system. And if you can recall, the thoracic region of your body, that's above the diaphragm. And so too is the brachiocephalic. So it's above the diaphragm, so it is not lower. So we can eliminate 36217 found at C. Gotta go. Now let's look up our other codes. All right, so the 36214 family, this is the selective catheter placement arterial system. Each first order abdominal, pelvic, and or lower extremity artery branch within a vascular family. We know this is below the diaphragm. We do. Right? We know. So 36245 is first order, 46 is second, 47, that's third order. Now, what do we have to do? Well, we have to decide or determine if our code is first, second, or third order. And how do we do it? Well, we got to go to Appendix L. It will tell us and it will give us the code, right? Okay, so this is our path: aorta, right iliac, external iliac, profunda femoris, and we're going to turn to appendix L and we're going to go right to the below diaphragm codes. We're going to bypass these because this is above the diaphragm. And these codes are below the diaphragm. Now let's go ahead and find our code. All right, so it says that the catheter was placed in the right iliac. According to our documentation, this was the first place that it landed, and we can deduce it is here. This is the common iliac, and the right is the laterality, right or left, right? So this is our first order. Then the catheter was placed in the external iliac, and you can find it right here. External iliac, and this is second order. And then finally, the catheter was advanced to the profunda femoris, and you can find it in the third order branch, right? So our answer or our code is 36247, third order. It's the highest, right? And it's also where the catheter ended. And if this is the code, then we have to eliminate first order. If you look at A, it's incorrect because it's coding for first order 36245. Gotta go. And we're going to keep both B and D because both are coding for the third order branch. And the difference between B and D are the radiology code 75716, 75710. How do you know that's radiology? Because when we study and we do this over and over, you'll come to know the different um, chapters. You'll know that 10,000 is in TAG, 20 is muscular, 30,000 is shared with radiology and cardiovascular. 40 is digestive, and we're going to be tackling that. And 50, that's your urinary male and female. 60 is nervous, and 70,000 is radiology. And angiography does fall in that category. So we can deduce that's what we'll need to code for. So let's go ahead and let's look up these codes. Let's look at B, 75716. This is the code for angiography, extremity, bilateral radiological supervision and interpretation, and 75710 is angiography, extremity, unilateral radiological supervision and interpretation. Okay, so I think we know where this is going. But before we say what the answer is, as you can see, hopefully you can see that knowing or following these FTRs will help you arrive at the answers. Okay, so we kind of use this. This was a good tool for us. So, based upon our documentation, which says we had an angiogram of the right lower extremity, there's no mention of anything bilateral. We know we can eliminate the bilateral code, and 75710 will be the correct angiography. So we eliminate B, and the answer is D. Okay, coders, how was that? Yes, it is involving, right? It does. It's a lot of steps, but pretty soon you'll get accustomed to recognizing the code language and you can almost tell the answer. If you do it enough, you'll be able to arrive at the answer very quickly. And you will if you do your practice exercises. And in the MCG, there are a lot. All right. So final fact to remember, chun your book. Yes, if you chun your book, you don't have to do a lot of that reading, right? And you don't even have to go to the appendix L for everything, right? You'll need to go, and I'm glad you know where it is. But remember, chun. Chun is life. Chun is everything. Okay, now we're going to turn our attention to our next subject, digestive system.
The digestive system, well, it's a group of organs that work together to help you digest and absorb food. And it also removes waste. And it's important in coding that you know the anatomy of the digestive system. So I took this image from your CPT manual, and I color coded it based upon the digestive process. Well, maybe not. Maybe I color coded it and I categorized digestive system anatomy. And then we're going to review the digestive process. All right, so first things first, the anatomy of the small intestine or bowel, the duodenum, jejunum, and ileum. Duodenum here, and it goes all the way down there about like a third, like their length is equal. So each represents 1/3 of the small intestines. So you've got your duodenum, your jejunum that kind of starts here, and your ileum that starts there, followed by the large intestine or bowel. This part of the intestines that actually sits around the small intestine. So it's around, and it's as follows. You have your cecum beginning here, your going up colon, transverse across, descending down. And then right about here, you have your sigmoid colon, then your rectum and anus. Now, the difference between the two, the small intestines, you use a scope that goes through the oral cavity, and you can view the small intestines, whereas the large intestines are viewed from the rectum. The scope is inserted into the rectum. Okay, so now that we know what small intestines are, large intestines are, there are some accessory organs that are very important. They're not a part of the digestive system, but they are accessory organs, your liver, your gallbladder, and your pancreas. Now, when you're coding, you will be asked to, well, when you're coding, you should understand the anatomy. So, specifically, the anatomy of the small intestines and the large. All right, so we're going to do some scenarios that will really help augment your understanding. But when you're coding, you'll be expected to code for the anatomy, not the scope that you're using. All right, so I want to move on just a bit, and I want to talk about chunning the digestive system because it's important. It's really important. If you're not chunning anything, you need to chun chapters that have lots of scopes. And digestive system's got a lot of scopes. Please chun the digestive system. All right, so just as a reminder, CHUN is the acronym for circle, highlight, underline, and notate, right? All right, so there are many scopes, and this is an example of how you can chun. Now, this is not the end all be all, but this is a way, and this is something that you can kind of model your chun after, or, always make it better. All right, so again, choose a primary highlighter color. We recommend yellow and a secondary color, right? Then you go ahead and you circle your families. All right, so in this image, we've got two families. And after you circle the family, you're going to highlight the language at the parent level behind the semicolon in your primary color. Also, you'll highlight the child. I tend to highlight the main information in the chapter 4. I try to keep highlighting to a minimum. I mean, if you're not really paying attention and if you follow the chun technique, your whole page could be yellow. So when you are chunning in the digestive system, try and keep that yellow highlighting to a minimum and use your notation technique to kind of supplement because you want to be able to see, and it's going to lose its significance if everything is yellow. All right, so this is how I did it behind the semicolon and just the main term within the child code, the main procedure. All right, and also my parenthetical guidelines are in green, and also these terms within the parentheses at the code level too. I'm not going to say these are guidelines, but they are notes that are in parentheses and they should be highlighted. All right. Also, don't forget to underline anything that needs to be emphasized. Right here we have this is the family for small intestinal endoscopy, enteroscopy, beyond second portion of duodenum, not including the ileum. All right. So the difference between this family and the family below, this includes the ileum. So definitely underline anything that needs to be distinguished. So I'm using my notes, and I'm going to put in my family that this is a endoscopy. Beyond second part of duodenum does not include the ileum. And then below, this includes the ileum. Also, I'm going to notate at the bottom of the page my FTRs, at the top of the page if it's not documented what this is. Also, you can notate at the code level. If it's cleaner for you not to notate by the code, you can notate to the right of the code. But in this case, we're notating at the code. Maybe next time I teach this, I'll do it opposite so you can see. But you can see at a glance, 44361 is a biopsy. 44363 is a foreign body. Snare is at 64. 65 is hot biopsy forceps. 66 is bleed control. 69 ablation. 70 is a stent. This is for jejunostomy tube. At 72 and 73, conversion. And these techniques are pretty standard throughout the digestive system. Not every single one, but you're going to see these over and over. And the digestive system does take it's one of the longest chapters to chun because of all of the scopes, but it's highly, highly recommended that you chun it. All right, so we have some do nots. Anytime you see do not, please put your asterisk next to it. And then finally, you've got your game changers, or box them in a different color. And at the top, we provided our notation. And that's it. So if you haven't already, if you want to screenshot this, go ahead. There's an icon at the top of your screen. Go ahead and push that icon. It's a camera and you can screenshot it. And also, if you want more ideas on how to chun, join the Facebook chun party. They are doing it. We got a special shout out to one of this person isn't even on Facebook. They are on TikTok. Yes, having their very own chun party. I said, well, way to go, way to go, way to go. All right. Now, I just want to talk to you all in the chat. All right. You all have some awesome, awesome ideas. Awesome. And they're coming through, and I want to shout them out. But you know what? I can't because I don't read that fast, but I do read everything. Everything. You all are amazing. Whatever you have to do to make things make sense to you, do it. All right. So we're talking about these scopes in the digestive system. Let's go ahead and let's talk about let's talk about the FTRs, right? The FTRs, facts to remember for the scopic procedures. So these pretty much pertain to scopes in the digestive system. Number one, we need to know what type of scope is it? Is it a rooter or a tutor? If it's a rooter, it goes through your mouth. Think about the roof of your mouth. And the tutor, you know where that goes. It's down there. Also, digestive scopes are bundled in the same surgical scope. And this is generally, there are some rules and circumstances that apply that kind of override this rule, but it's a general rule. Also, Diagnostic scopes performed with an open procedure are coded separately. Colonoscopies. When you have a colonoscopy, use modifier 53 if the doctor has to discontinue a diagnostic scope procedure, and use modifier 52 if the doctor has to discontinue a therapeutic scope procedure. Watch Medicare or HCPCS colonoscopies. If a patient has Medicare, we will not use CPT codes. We'll have to use HCPCS level 2 codes generally. All right. Make sure you code the anatomy viewed, not the scope, the anatomy. And also watch those separate procedures because they're going to help you. They're going to remind you, like, hey, this separate procedure is coded separately. However, if you see it with another procedure, it should be related. It should be not related in order to code it. If it's with another procedure that it's related to, it's bundled, right? All right, we'll talk more about that. And anytime the doctor removes a diagnostic scope, then reinserts another scope for a surgical procedure, you can code that diagnostic scope separately, okay? All right, so speaking of scopes, I had a book that the AMA gave me, and it's called Principles of CPT Coding. I love that book, but they don't make it anymore. But what they did do, they had this table in there. And I loved this table because the table described the scope and what the code range was. And it gave me an opportunity to place how far it views, the anatomy that it views. So if you have an esophagoscopy, code range is 43180 through 43232. And this code range could be wrong because, like I said, this is old, but an esophagoscopy views the esophagus. That's straightforward, right? An esophagogastroduodenoscopy, or an EGD, it views the esophagus, the stomach, and the duodenum. If a patient has an endoscopic retrograde pancreatography, or ERCP, and they're looking at pancreas and the bile ducts. That's pretty much what they're looking at. And an enteroscopy, enter means intestine. That's the duodenum, jejunum, and ileum. In ileoscopy, that's the lower part of the small intestines, the ileum, the farther, the most distal part of the ileum. Colonoscopy through a stoma. This is viewing the large intestines through a stoma. A proctosigmoidoscopy. This is viewing the rectum and the lower sigmoid colon. And then you have a sigmoidoscopy. This is your rectum. You're viewing the rectum, the sigmoid, and the descending colons. A colonoscopy, of course, views the entire large intestine. And then you have an anoscopy, or an anoscopy. That's the anus and the rectum. So the esophagus, the EGD, ERCP, enteroscopy, and the ileoscopy, these are your tutors. And the scope goes through the mouth, whereas the colonoscopy, well, we're not going to say the one through the stoma. That would be incorrect, but let's leave the stoma out because the scope is going through the stoma. But and I'm going to fix it now, but your colonoscopy, and your anoscopy, those are tutors. They go through the rectum and anus. Okay, we're going to go back because I want you to see it. And also, too, if you want to screenshot this, feel free. It is in your handout, too, so you don't really have to. All right. Okay, coders, how are you? I didn't ask how you were. I just got Busy. I got right to the point. Everybody good? Okay, okay. All right. Now, let's remember that, of course, this is a surgery or surgical section. So, of course, surgery guidelines apply. So make sure you keep them in mind. Also, when you are chunning, feel free to use your MCG manual. That's where you can get your FTRs for the digestive, urinary, and male guidelines. Now, I'm ready to get into it. Are you ready? You guys ready for a coding exercise? Yes, let's do it. Let's do it. All right. What is or are the correct CPT codes to report? A 44388, B 44360, C 45330, or D 45378. A patient presents to the endoscopy suite. The gastroenterologist advances the flexible scope past the the transverse colon to the cecum. All right, coders, what is the correct answer? You have 1 minute. I know that's not a lot of time. So place your answers in the chat. And if you want to, you can put your keywords there too. Your time begins now. All right. I know that even though it says you had 1 minute, I think that's a 2 minute clock. And I think you needed more time. I don't think that was ample for a first scenario. All right. So the first thing I'm going to do is highlight my key terms. The endoscopy suite. I don't know what that means, but it's pink. I don't know if I need to document it. Your flexible scope, your transverse colon, and your cecum. Okay, coders, if you can you recall what part of the digestive system that these areas, well, they're talking about scope, but where is the cecum? Does anybody know? Type in the chat. Is it your small intestine, large intestine? Is it an accessory? Yeah, it's your large bowel. Like, how do you know that, Mrs. J? Well, in CPT, they define pretty much what these scopes are. They do. And they say colonoscopy is the examination of the entire colon from the rectum to the cecum, and it may include examination of the terminal ileum or small intestine proximal to an anastomosis. Well, in other words, if it's in general the entire colon, let's take a look at this. Remember, this is a tutor, so that scope is going up the rectum. So it's going up the rectum and going all the way around, and all of the blue are being viewed. All right, so the rectum, and they said this scope went past the transverse colon. So it went up the rectum, past this part here to the cecum. Cecum is down here. What kind of scope is that? If you're viewing the large intestine, it's a colonoscopy. All right. Okay. So now I want to just draw your attention to the FTR. Make sure you view the anatomy. You code the anatomy viewed, not the scope. And also, here's a coding tip. Select the scope that can view all of the anatomy in your documentation. So to the cecum, it better be a colonoscopy. So if we look at the first answer, 44388, this is a colonoscopy through a stoma, right? Through a stoma. And a stoma is defined as, sorry about that. A stoma is defined as any opening in the body, such as a colostomy, right? So in our case, this code is for a colostomy, which connects this through this hole right here. It connects to your digestive system to allow waste, specifically feces, to be eliminated. All right, so let's get rid of that. And this A did not happen. So we got to get rid of it. It's a distraction. Our next code is 44630, and it's coming up wrong because this is coding for duodenum, jejunum. So these are your small intestines, right? Duodenum, jejunum, these are part of your small intestines. So we are coding for large intestines, large bowel, and therefore B, 44360, you got to go to. And then 45330, this is a sigmoidoscopy. So the scope, a sigmoidoscopy, when you take the scope, enter it through the rectum, it stops around here, right? The sigmoid colon. So that's not going to do the trick. We need a scope that can view the entire large bowel. So therefore, 45330 is gone. And that leaves us with 45378, colonoscopy, flexible, diagnostic, including collection of specimen by brushing or washing when performed. So this D, 45378, is our answer. How are you doing? All right, someone said they're calling the alphabet. Someone said they're kind of getting it. You know what? Through practice, you're going to get it. Someone had a teachable moment. Someone's good. Outstanding. All right, we have another scenario. The correct CPT code is A, 44005, B, 4418022 modifier, C, 00522 modifier, and D 44,180,59 modifier. An 82-year-old female had a CAT scan which revealed evidence of a proximal small bowel obstruction. She was taken to the OR where an elliptical abdominal incision was made, excising the skin and subcutaneous tissue. There were extensive adhesions along the entire length of the small bowel. The omentum and bowel were stuck up to the anterior abdominal wall. Time-consuming, tedious lysis of adhesions was performed to free up the entire length of the gastrointestinal tract, from the ligament to traits to the ileocolic anastomosis. The correct CPT code is, all right, coders, your time begins now. Okay, coders, I see. You know what? I think we're getting it. Yes. All right. Here are my keywords. CAT scan, and it's in pink. So I don't know what to do with it or if it's significant, so it's pink. But I'm going to document only yellow and green. Proximal small bowel obstruction, elliptical abdominal incision, excising, extensive adhesions, omentum and bowel were stuck up to the anterior abdominal wall. This was time-consuming, tedious, lysis of adhesions performed. So my proximal small bowel obstruction, elliptical abdominal incision, extensive adhesions, time-consuming and tedious lysis of adhesions. Do you all see how I inventory? Often I just break it out so I can see it and also code it. So what took place here? Well, it says it was time-consuming and tedious, so it might be we might need that modifier 22, right? That modifier 22 says increased procedural service, right? And it can help you select, or eliminate a code. But often I want to caution you, some of the codes have that time-consuming or tedious component in the code, and it will tell you, it'll say this is for an extensive procedure. So make sure that if the code reads extensive or difficult or anything, synonymous to that, don't put a modifier 22 on it because it's inherent in the code. All right. So what happened? Well, this is an example of an intestinal adhesions. And I don't know if this describes our procedure. So I went to the trusted internet and I said, okay, let me see what you got. Help me understand what happened. Well, in this first image here, this is normal intestines without any adhesions. Now this one here, the adhesions are beginning to form, and this gives us sort of like a timeline of the development of adhesions. So this is just hours after surgery. That's how fast these adhesions can actually form. Then days after surgery, you'll see a more denser view. And then 3 weeks to months after surgery, significantly more. And then I would say, anytime from months after to present, it starts looking like this, matting adhesions. I don't know, but it looks like that our situation is this or something like this for the doctor to say it was extensive. So something like the one down here in the lower right hand corner. So the doctor had some work to do. So let's go ahead and let's code this. So 44005, this is the code for interolysis. Inter is the root or the word root for intestines. Olysis or lysis, that's freeing, right? So if you look inside the parentheses, it's telling you this is freeing of intestinal adhesion. So I like this code. Didn't that happen? And if you look at 44180, this is the code for a laparoscopic surgical interolysis. There's no mention of any laparoscope. In fact, it describes an elliptical abdominal incision. So we're not going to code for this laparoscopy, and we're going to get rid of it at B and D. And that just leaves with 44005. And you know what? We can use that increased procedural service because when the work required to provide a service is substantially greater than typically required, it may be identified by adding modifier 22 to the usual procedure. Now, the documentation must support the substantial additional work and the reason for the additional work. So we're going to say that it was time-consuming and tedious, and that is sufficient. All right, so we're going to get rid of A, 44005, and C is our answer. You are rocking it, rocking it. And yes, just take your time. And also, too, some of this information is presented a little differently, more direct than your main lecture. Often I do that. I try to refine it and I try to make it a little more clear. So this, you might just be getting it now. And if you're getting it now, wait until you start coding it. Okay, so don't be expected to get it right if this is like the first time you're actually hearing it this way. All right, so pat yourselves on the back and keep going because you're getting ready to rock this. Pat yourself on the back in advance. And for all of you that got it correct, outstanding. And for those who had an aha moment, that is priceless. All right, all right. Now we got another scenario. Let's get into it. How should you report this type of procedure? A, 44130, B, 44120 times 4, C, 44111, and D, 44120, 44121 times 3. A patient underwent an enterectomy of the small intestine with 4 resections and anastomosis. All right, coders, I think you have 2 minutes and your time starts now. All right, I see a lot of great answers and I see some aha moments coming. Let's get started. We're going to begin with our inventory. Patient underwent an enterectomy. Enter is the word root for intestines. Ectomy means removal. So they removed 4 sections. All right. And they carried out anastomosis. Okay. Enterectomy, small intestine, 4 resections, and anastomosis. Now, what did they do? Remember, I said that the small intestines kind of live inside, not in it, but in between the large intestines. So essentially, they made 4 resections. So they cut out 4 pieces. Cut here. Let's just say they cut here, 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 and here. 4 sections, cut them out. And then essentially they put it back or rewired it. They got to kind of make it fit, right? So they sewed it back or rewired, and they call that anastomosis. Now, let's code it. So if we go to the parent of 44111 at 44110, this is an excision of 1 or more lesions. Coders. There was no mention of an excision of a lesion, right? And then they say it doesn't require anastomosis. We know that anastomosis took place. So this is doubly wrong. And then if you read the whole family, well, we're going to read 44111, the dependent. This is for multiple enterotomy, not an enterectomy. So this code 44111 is 100% incorrect. So it's a distraction, gotta go. Next, 44130. This is the code for an enterostomy. Wait a minute, ostomy? Our procedure is not an enterostomy. No, we didn't create any openings. We removed a piece of the intestine. So, wrong procedure. Let's go ahead and get rid of 44130. And that leaves us with B and D. So if we look at 44120, it's incorrect. Here's why. Because this is coding for an enterectomy, which is correct, or resection of small intestine, but this says single resection and anastomosis, which is technically correct. However, it cannot be coded. You can't code 4 units of it when you have the 44121. All right. So you have to code 44120 with 44121. This 44120 is for only one or a single resection. You do not add units to a single resection when you have an add-on code. So the add-on code really does it. It says each additional resection and anastomosis list separately in addition to the primary procedure. So indeed, you do it. And also too, look at this parenthetical guideline here. It tells you to use 44121 in conjunction with 44120. So make sure you highlight that. That's why that says that. So you don't go ahead and code a B, right? It's telling you to use them in conjunction. So we have 4 resections. We're going to code the first one with the first code and the additional with 3 units. And also, we're coding for the anastomosis, right? B doesn't code for the anastomosis or the rewiring. And our answer is D. How you doing? All right, someone said they're doing good. They're having an aha moment. Someone's doing great. Someone said, I'm okay. All right, someone's rocking and rolling. Good deal. If you're learning, you are rocking and rolling. This, don't expect to get everything right. You know what I mean? But expect to learn something. And if you're learning something, come on, you've learned it, and that's priceless.
Fantastic job, coders. We have completed week 12 and we discussed the CPT cardiovascular system, digestive system. We practiced exercises to test your knowledge, and I did give you a testing gem. And coders, hopefully, we brought you one step closer to CPT coding mastery. Now, let's go ahead and discuss the homework for week 12 very quickly. If you're new to this course, you probably should start at week 1, but you'll need to go to www.amcicoding.com, click on YouTube course to locate the syllabus. You'll see right here. There is the syllabus, but before you get into the syllabus, make sure you read everything on the website. When you click on the syllabus, you'll see the books, the required texts for this course. And now let's discuss the homework. Number one, if you are in Discord, go ahead and download the class PowerPoint handout. There you go. Number two, watch the playback of this session if you need to, right there. Number three, go ahead and complete your reading assignment. That's Unit 3, Chapter 17, Bucks, Step by Step, the Cardiovascular System. And number four, go ahead and watch the cardiovascular lecture from the MCG. You have to go into the MCG, click on charts, videos, exams, and additional resources, and then you'll see these QR codes. Click the QR code that says lecture. All right. You'll see these lectures here and click on cardiovascular. Number five, we have an optional lecture on how to code long scenarios. Some people want to know. So there you go, it's optional. So click the green link and the cardiovascular parts 1 and 2. Number 6, Chun, the cardiovascular CPT section. In your manual, yes, you're ready to chun it. Go ahead. If you need some assistance, see that blue hyperlink? There is where you can get it. You can join the AMCI Chun group, and your peers have provided you with their Chun. Now, if you're a gold or platinum member, you should have access to the instructor's Chun. But if you want to join the Chun group, click that blue link. Also, there is a link in the chat. Go ahead and share it, team. It's on the corresponding slide. And once you get in that Chun group, click on Media, then Album, and you'll see all of the Chun. Yes, it's older Chun, but it's good example. And coders, we really, really don't encourage you to copy Chun word for word. You have to make it make sense for you. So please go ahead and use this to your liking. Number 7, complete the MCG cardiovascular quiz. Go ahead and do it. You can access it from your MCG manual. Charts, video, exam, and additional resources. Click on this link. It's a hyperlink if you have the ebook, or there is a QR code or link. You may use it. So there is your quiz. Click on cardiovascular. There you go. Number 8, read Bucks Chapter 3, Unit 3, Chapter 19, Digestive System. Number 9, watch Chun lecture on digestive system from the manual, right? Number 10, optional, watch how to code a long digestive case scenario. Number 11, Chun, the digestive system. Number 12, complete the digestive system quiz in the MCG manual. And if you want that extra, or if your hands aren't free and you want to listen to our podcast, go ahead. We invite you. You can find the corresponding lectures on the podcast. And the link is on your syllabus. So that is all for homework. Don't forget to attend Friday Night Live. Don't forget to attend I'm Tap. That's on Wednesdays. And next week, we'll be discussing urinary male and female systems. So, on that note, I know that we've gone all the way to the brink. So, I want to thank you very much in advance for completing our survey. Don't forget to complete that survey. We need to hear from you. We need to know who you recommend for exam prep. We need that too. And don't forget to like up this lecture. week 12 if you enjoyed it or you learned something. If you didn't, you can thumbs down it. It's okay. We need to know. Thank you, team. I honor you. You are incredible. And thank you so much for showing up with purpose and passion. You are the best. Okay, and thank you, coders, for coming each week and putting in the work. Remember, coders, you're not just learning codes, you're learning how to think like a world class coder. Stay focused, stay forensic, and never forget why you started.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around the world. AMCI, AMCI.